You can see why we saved Dr. Safe, right? That was fantastic. Thank you so much. Thank you for outlining the way forward and what hope looks like. The continuum of care for all cancer patients involves a number of aspects, dimensions, and components that are a lot more subtle than chemotherapy, radiation therapy, and surgery. And that is often called palliative care. Palliative care has certain connotations that are completely unfair and inappropriate. Palliative care provides a spectrum of support for patients that is crucial. And this morning, you heard a number of survivors speak about it specifically. So we are extremely pleased and very excited to have Dr. James T. D'Olimpio from Northwell, who is the Director of Palliative Care for Northwell, to help us understand what palliative care has to offer for the young adult colorectal cancer patient. Thank you, Dr. D'Olimpio.
Thank you, Dr. Weber, for the introduction and for the invitation, as well as Dr. Barakat, and Cindy's help has been really phenomenal. I'm a palliative care doctor, and I'm also an oncologist, and when I was told that I had 10 minutes to do this, it was a little difficult, but I'm also a musician and a pianist by avocation, and I've played around here in Manhattan a few times. And I had a great teacher, and she told me a quote from Rachmaninoff. And the quote, he was a wonderful, if you know Rachmaninoff, he was a pianist and composer, very famous. And he once said about the audience would be that always create a tension and leave the audience wanting more. So with that in mind, I thought maybe, when I spoke to Cindy about this, I'm going to be compelling and I'm going to be as brief as I possibly can be in the same time frame. So this is a prop. This is called the Clinical Practice Guidelines for Quality Palliative Care. It's 190 pages long. It was published by the National Consensus Project, the National Coalition for Hospice and Palliative Care. It's the 4th edition. It just came out. And it's really wonderful, and it has a lot of process in it. It has a lot of sort of steps in terms of creating quality metrics and things that we're very interested in, especially in this world of electronic medical records. And the problem with it, though, is, and I read through the whole thing, and the problem with it is that it was put together by palliativists. And when you look at the sponsorships of the endorsements of this great tome, what was missing was the American Society of Clinical Oncology and the Multinational Association for Supportive Care in Cancer. There were no cancer-related organizations that helped put this together. So what does that mean? That means that there might be a gap in terms of our understanding of what palliative care is and what supportive care is. And I was hoping to just sort of bring that together and be a little provocative about it at the same time. So our goal here really today is to talk about supportive and palliative care. What are the gaps faced by the early age onset colorectal patient? Is this something that I can use for, I'm sorry. I think I needed a clicker.
Right. So this will advance it.
Thank you. Thank you. And the red thing is...
This is the red.
I appreciate it. Thank you. All right. So what do we mean by gaps? Well, I sort of put this together as a way of understanding what supportive and palliative care is and what it isn't. So I thought we could understand it that way better. And gaps in effective models that extrapolate cost effectiveness from inpatient to outpatient was part of what I was asked to talk about a little bit. And gaps in bridging what I would consider to be best practice where the expertise doesn't exist, where even in a place like Long Island, where there's a lot of expertise, there's not a lot of that expertise in terms of best practice for palliative/supportive care. So you can imagine what it's like in the middle of the country, where we have a concentration of palliativists in the Northeast and in the Southwest, but pretty much everywhere else, except for maybe certain pockets, there's very little expertise in terms of best practice. And gaps in the math of availability of board-certified palliative care doctors who are trained in oncology. Now, I've brought this up at the Academy's meetings, and I've said, look, We have an embedded palliativist in our office who's been trained in oncology, who's wonderful, and has the ability to understand what's going on with our oncology patients. But that is a rarity. That is not something that we see all the time, so we have to be able to bridge these gaps. And when you do the math of availability, there are about 5,000 board-certified palliativists in the country, and about 500 board-certified palliativists/oncologists in the country, me being one of them. So what we're trying to do here is understand this to a much greater extent. So here's the composite evolutionary definition of supportive and palliative care. And the original definition of palliative care was taken out of hospice care, which was developed by the World Health Organization in the pretty much late 80s, early 90s. And basically what it tells us is, and I'm not sure I'm able to get this to press. That's okay. Just look at the top part of the goal of palliative care is to prevent and relieve suffering and to support the best quality of life of patients and their families. Palliative care is both a philosophy of care and an organized, highly structured system, which now has a board certification. As such, it can be delivered concurrently with life-prolonging care or as the main focus of care and can be defined in the setting of supportive care. Now, that's a decent definition. Oh, thank you. I didn't have a laser there. Okay. So here's where supportive care sort of came in. But here's the Multinational Association for Supportive Care in Cancer, of which we are also members. And they define it differently. They define it as the prevention and treatment of the adverse effects of cancer and its treatment. Rehabilitation, secondary cancer prevention, survivorship, and end-of-life care are all integral to supportive care. Thus, supportive care, and this is the most important sentence of my entire talk, has a wider scope than traditional palliative care. So what have we done to make that happen in our institution, and a model has been created by MD Anderson that actually made this work, and that has to do with rebranding it and calling our palliative care clinic a supportive/palliative care clinic or a supportive care clinic. And when this was done, there was a 40 to 50% increase in referrals. And that's very interesting because all we had to do was change a word. And when we changed that word, this is what we found. So moving forward, this is a brief discussion, basically a bottom line slide with regards to the cost effectiveness of palliative care. I don't have to show you a lot of slides. This is just one of them, which is an example. And the example is that in this situation, compared to usual care, palliative care consultations result in significant cost savings for inpatients. So this has been extrapolated to outpatients in rudimentary ways, and we also know that it also prevents, in many ways, unnecessary referrals to emergency rooms because symptoms are so much better controlled, and dialogues with regards to goals of care are also better put together. So these are the kinds of numbers that we put together, and when this goes forward in terms of other studies that have been done, and this came out of CAPC, that's the Center to Advance Palliative Care, this is what we found. So what are the potential gap-filling or bridging aspects that we can look at? Well, we need to develop more metrics that measure specific outcomes in specific populations which do not exist right now. So we have our work cut out for us. That's with specific reference to early age onset colorectal cancer, how best to incorporate supportive care and palliative care earlier is better in the era of EMR, where we can sort of put things together and be able to put them back, look forward. And is rebranding of the term palliative care to supportive care necessary? Well, it kind of depends on the culture that you're in, and this is something that we need to also look at. And how best to resource supportive care and palliative care, the interdisciplinary team approach, which is idiosyncratic to each individual institution. Our institution has had this program now for almost 22 years, and it's taken 22 years to get it to the point where it's at right now. It's not proper English, but that's okay. And what do we know so far about palliative care or supportive care for the outpatient? Well, we know the evidence tells us that outpatient palliative care's benefit is stronger for quality of life, resource utilization outcomes, patient satisfaction, very important in this day and age, and mood outcomes. But there's weaker evidence suggesting benefits on survival, despite what the New England Journal has published with regards to early palliative care referral can lead to better survival components in patients with metastatic disease. That is true, but it's trying to be proven in other areas as well. But these observations are consistent with the fact that outpatient palliative care programs are designed to increase patient social support, patient self-advocacy, and coordinated medical care, while palliative care is not focused on improved survival as an indicator of effectiveness. The survival benefit may be mediated by the other more directly influences outcomes of interest, such as what we offer in supportive care. So these are the kinds of things that I think are really important for this. And this is my last slide, so I'm pretty much right on time. And that is, what are our future directions? If earlier referral is better, and we seem to be able to say that the evidence is showing us this, how is it better? With specific regards to the early age onset CRC patient, which is not mentioned in the very least in the clinical practice guideline. You don't see one particular area about that there. So improved symptom management, both short and long term. Is it unique to this group? There are specific areas that we need to look at. For example, patients receiving oxaliplatin-based chemotherapy will have a different set of symptom clusters than those that are treated with immunotherapy as we move forward with this treatment. Less necessary hospitalizations, intervention in the emergency room, which are tremendously traumatic to patients and their families. This is what we've been able to show so far, at least in preliminary results. Improved survival in metastatic cases. Again, we're starting to see that. And Dr. Saif and other speakers actually started to show that as well in terms of our ability to improve survival with our new treatments. And improve survivorship in those cured. And this is what we're going to talk about tomorrow as well, because we have a wonderful panel tomorrow that's represented across the disciplines. We have patient advocacy, we have social work, we have coordinators, we have a lot of different people who will be able to help us with this in terms of what we really need to do and talk about in the panel tomorrow for a good hour. So improved survivorship in those cured, that is improved quality of life, cognitive impairment, which is a big interest of mine that I'm involved with MASC, peripheral neuropathy as well, PTSD-like symptoms, which really haven't been discussed very much, but are very important, I think, in the young person especially. Nutritional aspects, which are very important with regards to the microbiome and how we're going to be able to look into that. Family dynamics and financial integrity, which is also very important in this age of inconsistent coverage. So I think I'll leave it at that, and I hope I gave you a whetted appetite, wanting more, and we'll have more tomorrow. Thank you.